Have you ever, gotten an antibiotic from your doctor and just wondered, what is actually going on inside? Like, how does this tiny pill fight off an infection? Or maybe why one type works for your kid's ear infection, but you need something totally different for, I don't know, a skin thing. It's something most of us experience, but the microscopic battle, this hidden warfare happening against invisible threats. It's actually pretty mind-blowing when you think about it.
Well, welcome to the Deep Dive. This is where we gather up a whole stack of complex information, lay it all out, and really dig into it to find those core insights. Today, we are diving headfirst into the fascinating and absolutely critical world of antibiotics. We've got a serious pile of notes and research here covering everything from, the nitty-gritty of how these drugs work at a microscopic level right up to the really big global challenges like antibiotic resistance.
Yeah, and our mission today really is to give you a solid foundation. We want to cut through some of that dense medical jargon, the stuff that can make it feel inaccessible, and just get to the crucial facts about antibiotics. We'll explore how they work, their different strategies, which bacteria they're good at targeting, where we typically use them in medicine, the side effects, because let's be honest, they all have them, and that really pressing issue of resistance. By the time we're done here, you should have a much clearer, maybe more nuanced picture of these incredibly powerful medications and, well, just how vital they are in modern medicine. Hopefully you'll have a few of those aha moments where things just click, transforming random facts into real understanding. What I find genuinely fascinating is how antibiotics aren't just like carpet bombing everything. They don't just generically kill bugs. They wage war on bacteria with incredible strategic precision, right down at the cellular level. They're specifically designed, almost like tiny guided missiles, to target vital bacterial processes, while, crucially, leaving our own human cells mostly unharmed. That selectivity is absolutely key.
Okay, selective toxicity. I like that.
Exactly. So we can break down the main battle plans these microscopic warriors use.
Okay, let's unpack that. So when we say an antibiotic works, it's basically using a strategy to take out a bacterial cell. Maybe we can visualize this, like picture a single bacterium. What's its first line of defense, and how do drugs get past it?
That's a perfect starting point. Imagine that bacterial cell is like a tiny, very rigid house. Its cell wall is absolutely crucial for survival. It's this tough outer shell that gives it structure and stops it from basically popping under pressure.
Okay, like its exoskeleton.
Sort of, yeah.
Yeah.
And some of the most common antibiotics, the cell wall synthesis inhibitors, have this really brilliant strategy. They go after the construction crew, building that wall. They undermine the bacteria's fundamental defense. This class includes really well-known ones: penicillins, cephalosporins, carbapenems, and monobactams. Now, what they all have in common is they bind to something called penicillin-binding proteins, or PBPs.
PBPs, okay.
Think of PBPs as the essential little construction workers, the enzymes doing the final critical step of building, cross-linking that wall. It's a process called transpeptidation.
Transpeptidation, got it.
So when these antibiotics latch onto the PBPs, they basically handcuff those workers. They stop that final construction step, and the result, the bacteria ends up with a weak, faulty wall. It's incredibly vulnerable.
So it just crumbles.
Pretty much. Without that strong wall, its own internal pressure, plus these things called autolytic enzymes, think of them as internal demolition enzymes that are always remodeling the wall. They just cause the cell to lyse, to burst open and die. It's a really elegant way to take them down. Now, within that same group, the cell wall inhibitors, there's another really important one, Vancomycin. It's a glycopeptide. It also targets the cell wall, but its tactic is slightly different. It's like using a different kind of sabotage tool.
How so?
Instead of going for the PBPs, the workers, vancomycin binds directly to one of the key building blocks before it even gets added to the wall, a molecule called D-alanine.
Ah, okay.
By binding to that building block, it physically blocks the next step, which is glycopeptide polymerization, basically, linking these blocks together into the long chains that make up the wall.
So it stops the supply chain before the workers can even use the bricks?
Precisely. And that distinct mechanism is exactly why vancomycin is often considered a big gun, a crucial option for certain resistant strains, especially ones like MRSA that have figured out how to change their PBPs to evade other antibiotics. Vancomycin hits them at a different weak spot in the construction process.
Okay, so stopping the wall construction is one major strategy. But if the cell wall is the house, what about the stuff inside? You mentioned proteins, like the bricks and mortar maybe, and the machinery making them. Can antibiotics mess with that too?
Absolutely. That's the next major battlefront. Proteins are essential for pretty much everything a bacterium does: building structures, carrying out reactions, replicating. So disrupting their protein factories is another highly effective strategy. These are the protein synthesis inhibitors.
Makes sense. How do they work?
Well, bacteria make proteins using machinery called ribosomes. Bacterial ribosomes are slightly different from ours, which is key for that selective toxicity. They have two main parts, or subunits, the 50S and the 30S. Different antibiotics cleverly target one or the other. For instance, drugs targeting the 50S subunit include the Macrolides. You'll recognize names like azithromycin, clarithromycin, erythromycin, and lincosamides, like clindamycin. Also, the oxazolidinones, such as linezolid and tetazolid, hit this target.
Okay, so a whole group targets this 50S part, but do they all do it the same way?
Good question. Not exactly. Macrolides, for example, kind of jam up the assembly line. They inhibit several steps, like transpeptidation, translocation, chain elongation, basically stopping the ribosome from adding more amino acids to the growing protein chain. Clindamycin is a bit more specific. It mainly stops the formation of the peptide bonds between the amino acids. And the oxazolidinones, like linezolid, are quite unique. They actually stop the whole protein-making process, the translation, from even starting. Really potent stuff.
Wow. And what about the other part, the 30S?
Right. The other main target is the 30S subunit. This is where tetracyclines like doxycycline and minocycline and Aminoglycosides, Daptomycin, tobramycin, amigacin come in.
Yeah.
Tetracyclines work by blocking the delivery truck, essentially. They prevent the aminoacyl tRNA, which carries the correct amino acid, from binding to the ribosome complex. So the right building blocks can't get to the assembly line.
Okay.
Aminoglycosides are interesting. They do a couple of things. They cause the ribosome to misread the genetic code, the mRNA instructions. So the factory starts making faulty, non-functional proteins. Junk, basically. They also mess with translocation, the movement of the ribosome along the instructions. So they either bring the wrong parts or make the factory totally misinterpret the blueprint, crippling the cell.
That's incredible precision. It's like sabotage at multiple levels. So antibiotics can stop the building of the outer wall. They can shut down the protein factories. But what about the absolute core, the blueprint itself, the DNA? Can they go after that?
You bet they can. That's another major strategy. DNA synthesis inhibitors go straight for the genetic material. The Fluoroquinolones are a prime example of drugs like ciprofloxacin and levofloxacin.
How do they target DNA?
They target two critical bacterial enzymes, DNA gyrase and DNA topoisomerase, the YI. These enzymes are essential for managing the bacterial DNA, unwinding it for replication, recoiling it, cutting and rejoining strands. They're like the librarians and organizers of the bacterial genome.
Right.
Fluoroquinolones bind to these enzymes and basically jam them up, causing breaks in the DNA strands. This generates DNA cleavage, halts DNA replication, and ultimately kills the bacteria. It's a direct hit on their ability to copy themselves or even read their own instructions properly. Then there's another one, metronidazole, which is in the nitroimidazole class. It works a bit differently, but also targets DNA. So what we call a prodrug. It needs to get inside the organism and get activated. Once inside, it forms these highly reactive intermediate compounds.
Reactive compounds.
Yeah, unstable molecules that directly attack the bacterial DNA. They cause the DNA helix to lose its structure, leading to strand breaks. It's like throwing a chemical wrench into the delicate DNA machinery. This severe damage stops protein synthesis too and leads to rapid bacterial death. It's particularly good against anaerobic bacteria, the ones that don't like oxygen.
Okay, so wall, proteins, DNA. What else does a bacterium need?
Energy.
Basic building blocks. Can antibiotics cut off those supply lines?
Exactly. Even if they can't build or copy DNA, bacteria need to synthesize essential nutrients to survive and grow. One critical pathway for many bacteria is making their own folic acid. And yes, we have antibiotics that target this, the folic acid pathway inhibitors.
Folic acid, like in vitamins?
Sort of, but bacteria make their own, whereas we get it from our diet. This difference is key.
Yeah.
The classic example here is a combination drug called cotrimoxazole. It's actually two drugs working together, sulfamethoxazole, or SMX, and trimethoprim, or TMP.
A two-pronged attack.
A very clever one. Sulfamethoxazole, SMX, inhibits an early step in the folic acid pathway, stopping the formation of dihydrofolic acid. Then, trimethoprim, TMP, inhibits a later, equally crucial step, blocking the reduction of that molecule into tetrahydrofolate, the active form.
So it hits the assembly line at two different points.
Precisely. Imagine folic acid is like an essential key. The bacteria needs to make DNA and RNA components. SMX stops them from making the first part of the key, and TMP stops them from finishing it. This sequential blockade completely cripples their ability to make these vital building blocks. And since our cells don't use this pathway, getting folic acid from food instead, these drugs are nicely selective for bacteria.
Okay, that's incredibly strategic. But what about just brute force. Are there any antibiotics that just like punch holes in the bacteria and make everything spill out, like popping a balloon?
Yes, there are. That's the cytoplasmic membrane damage strategy. It's definitely more direct. Colistin is a prime example. It acts like a cation detergent, basically, a strong soap.
Yeah.
Yeah, it disrupts and damages the bacterial cytoplasmic membrane. That's the delicate inner skin inside the cell wall. This damage causes rapid leakage of all the essential stuff inside the cell ions, metabolites, everything just spills out. The cell essentially bursts. It's very powerful, but because it can also be a bit harsh, it's often reserved for really nasty multi-drug resistant infections where other options have failed. And then there's daptomycin. It also targets the cell membrane, but in a slightly different way. It binds to the membrane and causes rapid depolarization.
Depolarization, what does that mean for the bacteria?
Think of the bacterial membrane like a tiny battery, maintaining an electrical charge or potential across it. This potential is vital for many cellular processes. Daptomycin basically shorts out that battery. It disrupts the electrical potential. And this rapid depolarization, this loss of charge, has a knock-on effect. It indirectly shuts down the synthesis of DNA, RNA, and protein inside the cell. So while it hits the membrane first, its ultimate effect is to stop all the critical internal machinery. It's quite a clever, indirect way to kill the bacterium.
Wow. So, okay, we have all these different attack strategies. Hitting the wall, the protein factories, the DNA, the supply lines, even punching holes in the membrane. It's like a whole arsenal of specialized weapons.
Exactly.
But who are these weapons designed for? You know, which bacteria do they actually work against? This must be where that spectrum of activity thing comes in you hear about, like knowing which weapon is right for which specific enemy.
Precisely.
Yeah.
Understanding the spectrum is absolutely fundamental because not all antibiotics work on all bacteria. Bacteria are broadly categorized, often by how they stain in a lab test, gram-positive and gram-negative. This difference relates mainly to their cell wall structure.
Right, the purple and pink ones from biology class.
That's the one. And those structural differences mean different antibiotics work better against one group or the other. Many antibiotics offer what we call broad gram-positive coverage. They're effective against common gram-positive culprits like Strep, Streptococcus, and Staphylococcus species, which cause tons of common infections, strep throat, skin infections, pneumonia.
Okay, so which ones cover those generally?
Well, many penicillins do, unless the bacteria makes an enzyme to break them down, which we'll get to. Early generation cephalosporins are good here too. Also macrolides, lincosamides like clindamycin, tetracyclines, some fluoroquinolones like levo and moxifloxacin, cotrimoxazole, the oxalidones like linezolid, daptomycin, phosphomycin. Quite a few have solid gram-positive activity. But within gram-positives, there are some important specifics and, frankly, some tough customers. For instance, listeria, that bug you can get from contaminated food. Natural penicillin and carbapenems cover that one well.
Okay.
Then you have Enterococci. These guys can be pretty hardy and cause infections, especially in hospitals. Natural penicillin might slow them down, but often doesn't kill them, and resistance is a problem. Ampicillin often needs a partner, like the Aminoglycoside gentamicin, to really pack a punch. Vancomycin covers some Enterococci. Carbapenems can cover E. faecalis, common species. But for the really resistant ones, especially vancomycin-resistant Enterococci or VRE.
VRE, yeah, you hear about that.
It's exactly. For VRE, we often need drugs like tigecycline or daptomycin. They become critical lifesavers. And this brings us to probably the most famous resistant gram-positive bug, MRSA, methicillin-resistant Staphylococcus aureus.
The superbug.
Right, and here's where it gets really critical to understand the spectrum. MRSA is a huge challenge because it's figured out how to resist many of our standard anti-Staphylococcus antibiotics. The M in MRSA stands for methicillin, an older penicillin, but it signifies resistance to that whole class of anti-staphylococcal penicillins and most cephalosporins too. They just don't work against MRSA because the bacteria change the target site, those PPPs we talked about.
So what does work against MRSA? What are the key fighters?
It's a more select group. Vancomycin is still a mainstay, often the first choice for serious MRSA infections. Other important options include clindamycin, cotrimoxazole, and then there are the newer or more specialized agents. Ceftaroline, a fifth-generation cephalosporin, is specifically designed to hit MRSA's altered PVPs. It's definitely considered one of the last resort options.
Last resort. Wow.
Yeah. Tigecycline, which is related to tetracyclines, is another powerful option, good for MRSA and VRE. The oxazolidinones, linezolid and tedazolid, are often reserved specifically for MRSA because of their unique mechanism. And daptomycin and phosphomycin also provide crucial MRSA coverage. Having this arsenal is vital, but the fact we need these specialized drugs really highlights the resistance threat.
Okay, so that's gram positives, including the tough ones like MRSA and VRE. What about the other side, the gram negatives?
Right, gram-negatives, they have an extra outer membrane layer, which can make them inherently harder for some drugs to penetrate. But many antibiotics do cover common gram-negatives like E. coli, Proteus, Klebsiella, the ones often causing UTIs and other infections.
Which ones are good for those?
Aminopenicillins can work if the bacteria isn't producing resistance enzymes. Cephalosporins generally have increasing gram-negative coverage as you go from first to fourth generation. Carbapenems have very broad coverage here. Monobactams, tetracyclines, Aminoglycosides, Fluoroquinolones, Protramoxazole all have activity against many common gram-negatives. But just like with gram-positives, there are some particularly challenging gram-negatives. Pseudomonas aeruginosa is a big one.
Pseudomonas. Sounds nasty.
It can be. It often causes serious infections in hospitals, especially in vulnerable patients, and it's notoriously resistant to many antibiotics. You need specific anti-pseudomonal drugs.
Like what?
Well, certain penicillins like piperacillin and ticarcillin, usually given with a beta-lactamase inhibitor to protect them. Some cephalosporins, specifically the third-gen ceftazidime and the fourth-gen cefepime. Most carbapenems, meropenem, imipenem, durapenem, are very important here. But interestingly, not ertapenem. Ertapenem has a narrower spectrum.
Huh, okay. Good to know.
Also, the monobactam astrionam works, and certain fluoroquinolones like ciprofloxacin are key Pseudomonas fighters. And then there's colistin, that membrane disruptor, often reserved as a last resort for multi-drug-resistant Pseudomonas. Another tough gram-negative is Acinetobacter, causes nasty infections, often in ICUs. Drugs like unicin, carbapenems, again, meropenem, imipenem, durapenem, pygecycline, aminoglycosides, and colistin might be used. And for notorious species like the ones causing gonorrhea or bacterial meningitis, natural penicillin can still work sometimes, but often third-gen cephalosporins like ceftriaxone are preferred, along with aminopenicillins, azithromycin, or sometimes carbapenems.
It's amazing how specific it gets. Okay, what about bacteria that live without oxygen? Anaerobes.
Ah, yes, anaerobes. Crucial players in infections where oxygen is scarce. Think deep wound infections inside the abdomen after surgery or appendicitis, dental abscesses. We knew drugs that covered these specifically.
And which ones are good for anaerobes?
Combination penicillins are great here. Augmentin, unicin, tazocin, the edited inhibitor, often helps broaden the anaerobic coverage too. Certain second-gen cephalosporins, called cephomycins, like cefoxitin and cefotenin, are known for good anaerobic coverage, especially against bacteroids, a common gut anaerobe. Carbapenems are excellent against anaerobes. Moxifloxacin, one of the fluoroquinolones, has good anaerobic activity. Clindamycin is a classic anti-anaerobe drug. And crucially, metronidazole is a powerhouse against many important anaerobes, including bacteroids and also Clostridioides difficile.
Okay, and then there are those atypicals you hear about, especially with pneumonia.
Right, the atypicals, these are bacteria like Mycoplasma, Legionella, Chlamydophila. They're atypical because they don't have standard cell walls or don't stain well. So many common antibiotics, especially beta-lactams, don't work well against them. They often cause respiratory infections.
So what do you use for them?
Macrolides are key. Azithromycin, clarithromycin cover all three of those main atypicals. Tetracyclines, like doxycycline, are also good for Mycoplasma and Legionella. And the respiratory fluoroquinolones, levofloxacin and moxifloxacin, have excellent atypical coverage, which is why they're often used for community-acquired pneumonia where these bugs might be involved.
Gotcha. And you mentioned Clostridioides difficile, C. diff. Again, that's a special case, right? Caused by antibiotics sometimes.
Exactly. C. diff is a nasty gram-positive anaerobe that lives in the gut. Normally, other gut bacteria keep it in check. But when antibiotics wipe out those good bacteria, C. diff can overgrow, produce toxins, and cause severe diarrhea and colitis.
So what do you use to treat the C. diff infection itself?
The main treatments specifically target C. diff in the gut. This includes oral vancomycin, importantly, given by mouth so it stays in the gut, unlike IV vancomycin, which treats systemic infections. There's also fidaxomicin, another oral antibiotic very specific for C. diff, and metronidazole can also be used, although often reserved for milder cases now.
Okay, this is a huge amount of information on mechanisms and targets. So how does this all translate into practice? When someone comes in with an infection, doctors often have to start treatment before they know exactly which bug it is, right? That's empiric therapy.
Precisely. Empiric therapy is making your best educated guess. You consider the likely pathogens based on the site of infection, skin, lungs, bladder, the patient's history, maybe local resistance patterns, and you choose an antibiotic that covers those most probable culprits. You often don't have time to wait 2-3 days for lab cultures to come back, especially if the patient is really sick.
Right, you need to act fast. So let's take some common scenarios. What about skin and soft tissue infections, SSTIs?
Okay, for uncomplicated SSTIs, maybe simple cellulitis often caused by strep or MSSA, methicillin-sensitive Staph aureus, you might use a first-gen cephalosporin like cefalexin or cefazolin, or an aminopenicillin like amoxicillin, sometimes a macrolide like azithromycin. If you strongly suspect or know it's MSSA, then the specific anti-staphylococcal penicillins like dicloxacillin or nafcillin are excellent choices because they're very potent against MSSA.
But what if it looks more serious? Or if you're worried about MRSA?
Good point. For complicated SSTIs like deep abscesses or terrifying things like necrotizing fasciitis, you need much broader, more aggressive coverage. This often involves carbapenems like meropenem or imipenem. Vancomycin is usually added empirically to cover MRSA until you know for sure. Delafloxacin is another option for serious skin infections. And for things like anal bites or diabetic foot ulcers, which are often polymicrobial, meaning multiple types of bacteria, including anaerobes, you typically use a combination penicillin like augmentin or unicin to get that broad coverage.
Makes sense. Okay, what about respiratory tract infections? Say, just a regular strep throat.
For classic strep throat, caused by Streptococcus pyogenes, simple natural penicillin, like penicillin V taken orally, is still the gold standard. Highly effective.
And things like ear infections, sinusitis.
For otitis media or sinusitis, often caused by Streptococcus pneumonia, Haemophilus influenza, or Moraxilla catarrhalis, high-dose amoxicillin is very common. Sometimes augmentin if resistance is a concern, or a second-gen cephalosporin like cefuroxime.
Now, pneumonia, that seems more complex. You mentioned community-acquired versus hospital-acquired.
Exactly. Community-acquired pneumonia, CAP, the kind you get out in the community, often requires covering not just common bacteria like strep pneumo, but also those atypicals we talked about, Mycoplasma, Legionella. So empiric choices often include a macrolide like azithromycin or doxycycline, the tetracycline, or a respiratory fluoroquinolone like levofloxacin or moxifloxacin. Sometimes a beta-lactam like ceftriaxone is added, especially for sicker patients.
And hospital-acquired pneumonia, HAP, that sounds worse.
It often is. HAP is usually caused by nastier, more resistant bacteria, including gram-negatives and potentially Pseudomonas or even MRSA, especially if the patient has been ventilated, VAP. So empiric therapy needs to be much broader. We're talking big gun antibiotics here. Piperacillin-tazobactam, tazocin, cefepimia, fourth-gen cephalosporin, or a carbapenem like meropenem or imipenem. Often vancomycin or linezolid is added if MRSA is suspected. You really have to cover all the bases until you get culture results.
Wow, big difference. Okay, another really common one, urinary tract infections, UTIs. What's the approach there?
For uncomplicated UTIs, simple bladder infections, cystitis, common culprits are E. coli, sometimes Staph saprophyticus, Klebsiella. Empiric options include cotrimoxazole, nitrofurantoin, which is great because it concentrates in the urine, or phosphomycin. Sometimes an aminopenicillin like amoxicillin or augmentin can be used, though resistance is increasing.
And if it's more serious, like a kidney infection, pyelonephritis.
Right. If the infection has moved up to the kidneys, or if it's considered a complicated UTI, example in a patient with catheters or structural issues, you need more potent drugs that get good levels in the kidney tissue and cover potentially more resistant gram-negatives. Here we often use third-gen cephalosporins like ceftriaxone, fluoroquinolones like ciprofloxacin or levofloxacin, or sometimes aminoglycosides. For very severe cases or suspected highly resistant organisms, carbapenems might be needed.
Okay. Are there other really specific infections where certain antibiotics are just the clear choice?
Oh, definitely. For syphilis, for decades, the absolute best treatment has been natural penicillin, specifically a long-acting form called penicillin G benzathine, given as an injection. It's still remarkably effective. One thing to watch for, though, is the Jarisch-Herxheimer reaction, JHR.
What's that?
It's an inflammatory reaction that can happen within the first 24 hours after starting treatment, especially for syphilis. As the bacteria die off rapidly, they release substances that trigger fever, chills, muscle aches, headache, sometimes a worsening rash. It's usually temporary and means the treatment is working, but patients need to be warned it might happen.
Good to know. What about infections in the brain, like meningitis? Getting drugs in there must be tricky.
Extremely tricky. This raises that important point about the blood-brain barrier. Not all antibiotics can cross it effectively to reach the cerebrospinal fluid, CSF.
Yeah.
However, third-generation cephalosporins like cefotaxime and ceftriaxone have excellent CSF penetration, which is why they are workhorses for bacterial meningitis. Carbapenems also get into the CSF well, and you typically need to use higher specific meningeal doses for these drugs when treating meningitis to ensure enough drug gets to the site of infection.
Okay, and intra-abdominal infections, like appendicitis bursting.
Yeah, intra-abdominal infections or peritonitis usually involve a mix of gram-negatives and anaerobes from the gut, so you need broad coverage. Combination penicillins like augmentin, onesin, or tetracyclines are common choices. The cephamycins, cefoxitin, and cefotin are good because of their bacteroids, anaerobe coverage. Carbapenems are very broad, and often metronidazole is added specifically for robust anaerobic coverage.
What about H. pylori, the stomach ulcer bacteria?
For Helicobacter pylori eradication, standard treatment is usually a triple therapy: 2 antibiotics plus a drug to reduce stomach acid, a proton pump inhibitor. The common antibiotics used are amoxicillin and clarithromycin, a macrolide. Sometimes metronidazole is substituted if there's penicillin allergy or resistance concerns.
And antibiotics before surgery, prophylaxis.
Right, surgical prophylaxis. The goal is to prevent infection at the surgical site. For most clean surgeries, a first-gen cephalosporin like cefazolin given shortly before incision is standard. If the surgery involves the gut or areas with anaerobes, a cephamycin like cefoxitin might be used. For major procedures or MRSA is a concern, like some orthopedic or cardiac surgeries, vancomycin might be the prophylactic choice.
And lastly, endocarditis, heart valve infections.
Endocarditis is a very serious infection requiring prolonged, high-dose intravenous antibiotics. The choice depends heavily on the specific bacteria involved, often Staph or Strep or Enterococci. Common regimens might include antistaphylococcal penicillins, potentially ampicillin plus gentamicin for synergy against Enterococci, or vancomycin if MRSA or resistant Enterococci are suspected or confirmed. It's complex and always guided by culture results when available.
Okay, so these drugs are incredibly powerful, incredibly targeted, but they're not magic bullets without consequence. There's always a trade-off, right? Side effects, risks. It's a balancing act.
Absolutely. It's crucial to understand that as helpful as antibiotics are, they are potent drugs with potential downsides. Like any powerful tool, you have to weigh the benefits against the risks. Safe and effective treatment means being aware of these potential adverse effects.
So what are some of the big categories of side effects we need to think about? Allergies seem like a major one.
Definitely. Hypersensitivity or allergic reactions are always a top concern. They can range from mild stuff like hives, urticaria, or a simple rash,
Yeah, I've had that.
right, to more severe reactions like angioedema, that deep tissue swelling, often around the face or throat. And the most feared one, anaphylaxis, which is a rapid, severe, potentially life-threatening whole-body reaction.
Okay, scary. And you hear about penicillin allergies all the time. What about cross-sensitivity? If you're allergic to penicillin, can you take related drugs?
That's a really important point about the beta-lactam group, penicillins, cephalosporins, carbapenems. They share a similar core chemical structure, that beta-lactam ring. So there is a potential for cross-sensitivity. If someone has a true severe penicillin allergy, like anaphylaxis, the risk of reacting to a cephalosporin is estimated around 10%, maybe a bit lower with newer generations. The risk with carbapenems is even lower, perhaps around 1%.
So not zero, but maybe not as high as people think.
Exactly. But it's still a vital consideration, especially with severe past reactions. Interestingly, the monobactam, Asdrionam, has a very different side chain structure, so cross-sensitivity with penicillin is generally considered unlikely, making it a potential option for some penicillin-allergic patients. Though, oddly, there might be some specific cross-reactivity with the ceftazidime because they share a similar side chain. And of course, if someone has a known allergy to sulfonamides, they absolutely need to avoid cotrimoxazole, which is a sulfa drug.
Okay. Besides allergies, what about gut issues? Diarrhea seems almost expected with antibiotics.
Yeah, gastrointestinal issues are super common. Simple diarrhea can happen with almost any antibiotic: penicillins, cephalosporins, macrolides, clindamycin, tetracyclines, phosphomycin, you name it. It's usually because the antibiotic disrupts the normal balance of bacteria in your gut, the microbiome.
Right, kills off the good guys too.
Exactly.
Yeah.
But the really serious gut issue we worry about is Clostridioides difficile colitis, or C. diff infection. As we touched on, this happens when broad-spectrum antibiotics wipe out so much of the normal gut flora that C. diff, which is often resistant, takes over and releases toxins, causing severe, persistent diarrhea and inflammation. This is a significant risk factor associated with many antibiotic classes, pretty much all the broad-spectrum ones we've mentioned. It's a major complication of antibiotic use.
Yeah, that sounds awful. What about damage to specific organs? You hear about drugs being hard on the kidneys or liver.
Yes, organ-specific toxicities are definitely a concern with certain antibiotics. The kidneys are a common target. Aminoglycosides, like gentamicin, have a well-known risk of nephrotoxicity, maybe affecting 10–20% of patients. Careful dose monitoring is essential. Vancomycin can also cause acute kidney injury, AKI, particularly with high doses, prolonged use, or in the elderly or those already with kidney issues. Colistin also carries a significant nephrotoxicity risk.
So you have to adjust doses sometimes.
Absolutely. Many antibiotics, including penicillins, cephalosporins, carbapenems, macrolides, aminoglycosides, require renal adjustment. This means the dose has to be lowered, or the interval between doses increased if a patient's kidneys aren't working well, to prevent the drug from building up to toxic levels.
Right.
It's standard practice.
And the liver.
The liver can also take a hit. Hepatotoxicity or liver damage can be seen with macrolides, tetracyclines, fluoroquinolones, cotrimoxazoles, and nitrofurantoin, among others. Liver function tests might be monitored during long courses of these drugs.
What about ears? Can antibiotics affect hearing?
Yes, ototoxicity. Vancomycin and aminoglycosides are the main culprits here. They can damage the inner ear, potentially causing hearing loss, sometimes permanent, or balance problems, vestibular toxicity. This risk is higher with high doses, long durations, and especially in children for aminoglycosides. Macrolides can also occasionally cause hearing issues.
Okay, kidneys, liver, ears. What about the heart? Any risks there?
Yes, cardiovascular effects are a critical consideration. Certain classes, notably macrolides and fluoroquinolones, carry a risk of QT interval prolongation.
QT interval. That's on an EKG, right? What does prolonging it do?
Exactly. It's a measure on the electrocardiogram related to the heart's electrical recharging time between beats. Prolonging this interval increases the risk of developing a dangerous type of irregular heartbeat called torsades de pointes, which can be fatal. So these drugs need to be used cautiously in patients with existing heart conditions or those taking other QT prolonging medications.
Yikes. Okay, that's serious. What about neurological effects? Effects on the brain or nerves?
Also possible. There's a risk of seizures with carbapenems. Particularly imipenicillistatin seems to have a higher risk than meropenem. High doses of cefepime can also lower the seizure threshold. Fluoroquinolones have an FDA warning about potential altered mental status, confusion, disorientation, hallucinations, and also peripheral neuropathy, which is nerve damage causing pain, tingling, or numbness in the hands and feet, which can sometimes be permanent.
Permanent, wow.
Yeah, it's a serious warning. High doses of penicillins or metronidazole can sometimes cause encephalopathy, a general brain dysfunction. Monobactams have been linked to neutropenia, low white blood cells, mainly in kids. Minocycline, a tetracycline, can cause dose-dependent vertigo, and aminoglycosides and clindamycin can cause neuromuscular blockade, potentially worsening conditions like myasthenia gravis, so they're used with caution there.
Okay, this is quite a list. Anything else? Muscles, bones, blood.
Yep, covers those two. Musculoskeletal effects. Fluoroquinolones have that infamous FDA warning for tendon rupture, most commonly the Achilles tendon. It's a rare but potentially debilitating side effect. Tetracyclines, as mentioned, can affect bone growth and cause tooth discoloration in young children, 12, and during pregnancy, so they're generally avoided. Daptomycin carries a risk of muscle pain or damage myopathy, even rhabdomyolysis, severe muscle breakdown, so doctors might pause statin drugs, cholesterol meds, during daptomycin therapy due to additive risk. Macrolides can also increase myopathy risk when taken with statins due to a drug interaction involving liver enzymes, CYP324, for blood disorders. Linezolid can cause myelosuppression, suppressing bone marrow function and leading to low blood cell counts, especially platelets. Tazocin and vancomycin have been linked to drug-induced immune thrombocytopenia, low platelets. And cotrimoxazole can cause various blood dyscrasias.
Okay. Are there any really specific, almost unique side effects tied to certain antibiotics? Things people should know about?
There are a few classics. Vancomycin flushing syndrome, sometimes still called red man syndrome, is one. This isn't a true allergy, but a reaction to infusing vancomycin too quickly.
What happens?
The rapid infusion triggers histamine release, causing flushing, redness, itching, especially on the upper body, neck, and face, and sometimes low blood pressure. The fix is simple. Stop the infusion, wait for it to resolve, maybe give an antihistamine, and then restart it at a much slower rate.
Yeah.
It's all about the infusion speed.
Okay, good to know it's manageable. What else?
Here's a really critical one, especially for newborns. Ceftriaxone and calcium. They should never be mixed in the same IV line or given close together without thorough flushing. They can form Precipitates, basically. Tiny solid particles in the bloodstream which can lodge in the lungs and kidneys and be fatal. It's a huge contraindication in neonates. Ceftriaxone can also cause biliary sludge or gallstones, and rarely kernicterus, a type of brain damage, in newborns.
Wow, that's a scary interaction.
It is. Then there's the potential disulfiram-like reaction with metronidazole if someone drinks alcohol. Causes nausea, vomiting, flushing, headache, similar to the drug Antabuse used for alcohol dependence. Though some recent data suggests this might not be as common or severe as once thought, the advice is generally still to avoid alcohol with metronidazole.
Probably wise.
Also, photosensitivity is common with Tetracyclines and Fluoroquinolones, makes your skin much more sensitive to sunlight, leading to easy and severe sunburns. Patients need to be counseled about sun protection. And finally, nitrofurantoin can turn urine a harmless brown color, which can be alarming if you're not expecting it.
Yeah, that would be a surprise. Okay, so clearly antibiotics are powerful but complex. And this brings us to maybe the biggest challenge of all. These drugs have been miracles, they've saved countless lives, but bacteria are smart, they adapt. And this whole issue of antibiotic resistance, it feels like it's getting worse. It's this constant arms race, isn't it?
It absolutely is. It's arguably one of the biggest threats to global health today. Bacteria are incredibly adaptable organisms, and they've developed numerous ways to fight back against the drugs we use to kill them. It's a continuous, evolving battle.
So how do they do it? What are their main resistance strategies?
One major mechanism is enzymatic inactivation. Basically, the bacteria produce enzymes that specifically chew up or modify the antibiotic molecule, rendering it useless before it can even do its job.
Like tiny defensive weapons.
Exactly. The classic example is penicillinase. This is an enzyme that many bacteria, especially over 90% of Staphylococcus aureus strains now, produce to specifically break down the beta-lactam ring of basic penicillins. That's why drugs like natural penicillin or ampicillin often don't work against staph anymore. The bacteria just destroys the drug.
Okay. And you mentioned beta-lactamases earlier. Is that related?
Penicillinase is a type of lactamase, but beta-lactamase is a broader term for enzymes that deactivate beta-lactam antibiotics, penicillins, cephalosporins, carbapenems. This is a huge mechanism of resistance.
So how do we fight that?
This is where clever drug design comes in. We developed volatamase inhibitors compounds like clavulanic acids, sulbactam, tazobactam. These don't have much antibiotic activity on their own, but they act as decoys. They bind to and inhibit the beta-lactamase enzyme, protecting the partner antibiotic. That's why we have combination drugs like augmentin, amoxicillin plus clavulanate, or tazocin, piperacillin plus tazobactam. The inhibitor sacrifices itself to let the penicillin do its work.
Ah, like providing covering fire.
Kind of, yeah. But bacteria have upped their game again, developing extended-spectrum beta-lactamases, ESBLs. These are more powerful enzymes that can destroy a much wider range of beta-lactamases, including many advanced cephalosporins. ESBL-producing bacteria, often gram-negatives like E. coli or Klebsiella, are a major problem, especially in hospitals.
So what works against ESBLs?
Carbapenems are generally the go-to drugs for serious ESBL infections. Ertapenems often reserved for ESBLs to try and preserve the broader carbapenems. Phosphomycin also has activity against ESBLs. And then there are even scarier enzymes like metallobeta-lactamases, MBLs, which can chew up even carbapenems. Interestingly, Astrionem, the monobactam, is often not broken down by MBLs, making it a critical option in some of those very difficult situations.
Wow, the bacteria just keep evolving new weapons. What else do they do besides destroying the drug?
Another major strategy is altered target sites. The antibiotic works by binding to a specific target in the bacterial cell, right? Well, the bacteria can subtly change the shape or structure of that target, so antibiotic can't bind effectively anymore. It's like changing the lock so the key doesn't fit.
Ah, and MRSA is an example of that.
Exactly. MRSA became resistant because it acquired a gene, MECA, that codes for an altered penicillin binding protein, PBP2A. Most beta-lactams simply can't bind well to this altered PBP, making them ineffective. It's a fundamental change in the bacteria structure to evade the drug.
And VRE, vancomycin resistance.
Same principle. VRE, vancomycin-resistant Enterococcus, develops resistance typically by changing the very end of the peptide building block that vancomycin binds to, changing edynyl-D-alanine to D-alanyl-D-lactate or D-alanyl-D-serine. Vancomycin just can't latch on properly anymore. Again, the bacteria modified the target. This is why drugs like Daptomycin or linezolid, which have different targets, become so important for VRE.
So they can destroy the drug or change the target? Any other tricks up their sleeve?
Oh yeah. Bacteria can also develop efflux pumps. Think of these like tiny pumps embedded in their cell membrane or wall that actively pump the antibiotic back out of the cell before it can reach a high enough concentration inside to be effective.
Like a bilge pump on a boat, just constantly pumping the water out.
Exactly like that. They just kick the drug out as fast as it comes in. This is a common mechanism of resistance for drugs like Tetracyclines, Macrolides, and Fluoroquinolones. They can also sometimes reduce the permeability of their outer membranes, making it harder for the antibiotic to get inside in the first place, like reinforcing the city walls.
It really is an arms race. So this directly connects to why some antibiotics are considered big guns or last resort, right? Because overuse drives this resistance.
Precisely.
Mm-hmm.
If we connect this to the bigger picture, drugs like tazocin, carbapenems, vancomycin, linezolid, they are powerful, broad-spectrum agents, invaluable for serious infections. But every time we use them, especially if it's not strictly necessary, we kill off the susceptible bacteria and leave behind any that happen to have some resistance mechanism. We are essentially selecting for resistance. Overuse puts immense pressure on bacteria to evolve and spread these resistance mechanisms. That's why we talk about last resort antibiotics. Drugs like ceftaroline for MRSA, tigecycline, MRSA, VRE resistant gram-negatives, linezolid, tedazolid, MRSA, daptomycin, serious gram-positives, colistin, highly resistant gram-negatives like CRE, Pseudomonas, phosphomycin, ESBLs resistant UTIs. They're often held back not necessarily because they're always better, but because we desperately need to preserve their effectiveness for situations where nothing else works.
It raises that tough question, doesn't it? How do we treat the patient in front of us effectively now while also protecting these precious resources for the future?
It's the central dilemma of antibiotic stewardship. And the emergence of things like CRE, carbapenem-resistant Enterobacteriaceae, makes this terrifyingly real. These are gram-negative bacteria resistant to carbapenems, often our most powerful drugs against them. Infections with CRE have very few treatment options, sometimes only colistin or newer, expensive combinations, and mortality rates are high. It's a stark warning about where resistance could lead us if we're not careful.
Wow. Okay, what an incredibly detailed deep dive that was. We've really covered the map here, from the intricate ways antibiotics attack bacteria at the molecular level, messing with their walls, proteins, DNA.
They're different mechanisms.
Right, to understanding which drugs target which specific bacteria, gram-positives, gram-negatives, those tricky anaerobes and atypicals. We looked at how this plays out in treating common infections like pneumonia, UTIs, skin infections, using that empiric approach.
And crucially, thinking about those potential adverse effects, the side effects, the contraindications like the ceftriaxone calcium issue or QT prolongation, the risks that always come with these powerful tools.
Yeah, the balancing act.
And then, maybe most critically, we tackled this urgent issue of antibiotic resistance, really understanding how bacteria fight back with enzymes like Beta-Lactamase by changing their targets like MRSA does, by pumping drugs out. It's this ongoing battle that really underscores why using antibiotics responsibly, antibiotic stewardship isn't just some abstract medical guideline. It's a global necessity. It affects everyone.
Absolutely. So after all this, maybe something for you, our listener, to kind of chew on. Consider this delicate balance we've been talking about. Every single time an antibiotic is used, we're not just fighting that infection in that person, we're also potentially nudging the evolutionary landscape, maybe contributing, even in a tiny way, to future resistance. How might understanding this intricate connection between treating today's illness and preserving tomorrow's cures change how you view what might seem like a simple antibiotic prescription? And maybe think about what role we all play as individuals in this huge, invisible, but incredibly important microscopic arms race.